of preoperative and intraoperative surgical patients. Minor surgery can often be performed in the provider's office, and practical nurses will assist more often with surgery in this form of clinical setting. Minimally invasive laparoscopic surgery can be performed more quickly. This type of surgery is done through small openings in the abdomen. This surgery also results in less trauma to tissue, a decreased inflammatory response, and causes less pain for the patient, plus a faster recovery. Medical robotics also provides a format for less invasive and less traumatic surgeries. A medical robot is operated from a computer while the surgeon views the magnified three-dimensional image of the surgical field on the computer screen. Terminology that is specific to surgery are suffixes of ectomy, lysis, oma, ostomy, otomy, plasty, and pexy. Surgeries are classified according to their necessity. It can be elective, meaning that it can happen at any time. Patient is stable, they've been to the doctor's office and made a scheduled appointment for surgery. It can be urgent, meaning it needs to happen within the next 24 to 48 hour window, or it can be considered as emergent, meaning it needs to happen right away. When looking at risk factors related to surgery, it can be a minor risk factor, procedures that have little to no risk involved, or it can be major risk. Usually these are longer procedures, more extensive procedures. When we also look at the extent of surgery, it can be a very simple surgery. For example, could be a hernia repair. Or it could be something that is radical where there is a mastectomy involved and then they're also doing a flap to cover up the area that has been exposed. Technological advances occur all the time in surgery, from laparoscopies, endoscopies, and robotics. Autologous blood for transfusions are pre-donated blood by the patient, or what's the use of a machine called a cell saver. For autologous blood donation, the patient's blood is withdrawn at the blood bank at the hospital several weeks prior to the surgery. It is then prepared and stored for the day of surgery. There is also bloodless surgery. This is the use of hemostasis products, red blood cell stimulating factors, as well as hemodilution. Bloodless surgery uses a combination of various techniques to minimize blood loss and maximize blood volume as well as functioning. There are various cultural considerations, and one is the religion of Jehovah's Witnesses. Followers of this religion will not accept a blood transfusion from another person due to their beliefs, because they believe that there are eternal consequences from receiving blood that is not their own. Prior to bloodless surgery, this has stopped them from having major surgeries. Now, due to the option of bloodless surgery, they can or will begin to have more extensive surgical procedures. For perioperative nursing, the assessment includes a focused assessment, a health history, and a psychosocial assessment, as well as cultural, spiritual, physical assessments with laboratory data and diagnostic testing information included. When the nurse assesses the pre-surgical patient, any deviations from the normal range should be brought to the attention of the surgeon. Patients greater than 75 years old have surgical complication rates 3 times higher than a younger adult. Latex allergies and latex-free environment. For a patient that is allergic to latex, they are at high risk of exposure during surgery when they are unconscious and unable to monitor the environment that they're in. Both contact and airborne precautions are necessary. Even rubber stoppers on medication vials or intravenous supply containers can be a problem for these individuals. The operating room is as latex-free as possible. For medications, it's vital to know if a patient is taking a corticosteroid because this can delay wound healing, alter fluid and electrolyte balance, and affect metabolic functioning in the body. All this will increase the surgical risk for the patient. Many individuals who are taking routine antiplatelets or anticoagulant medications for cardiovascular disorders and vitamin E, as well as other non-steroidal anti-inflammatories, have a continuing effect on blood clotting for several days. These medications are usually discontinued 7 to 14 days prior to surgery. The nutritional status and body weight are significant factors in healing and repair of the surgical site. Obese patients present problems for routine procedures, even venipuncture and intubation for general anesthesia. And obesity causes prolonged uptake of anesthetic drugs. Complementary and alternative therapies that patients use, like black cohosh, St. John's wort, feverfew, valerian, golden seal, licorice, and kava, can have interactions with other medications and anesthetics, and these need to be stopped 2 to 3 weeks before surgery. Ginger, feverfew, garlic, ginseng, and ginkgo biloba all have adverse effects on clotting mechanisms. When considering laboratory and pre-test data, it usually includes a CBC, urinalysis, a PT-INR, a PTT, blood type and cross-match. A pregnancy test for women of childbearing age is always done. A metabolic panel, a liver functioning test that includes an AST, an ALT, as well as a bilirubin. Renal function test, including BUN and creatinine. Blood glucose, electrolytes, EKG, and a chest x-ray. Cultural beliefs and values regarding surgery have to be taken into consideration. If a female patient's culture has strict rules for the female attire, the individual needs reassurance of sufficient privacy and protection of modesty. If there are cultural taboos regarding an aspect of surgery, the surgical team needs to know about them and plan a way to achieve a good outcome with violating any such taboos. It is also vital to know whether the patient will accept a blood transfusion. Most hospitals require a signed power of attorney for healthcare, declaring a healthcare proxy to be on the chart before surgery. Patients have the right to change their mind and revoke consent until the time of surgery. If a patient states the surgery is not wanted, the nurse should delay pre-op preparations and explore the issue with the patient. If it appears that the consent for surgery is really being revoked, the charge nurse should be notified as well as the surgeon. Routinely, the surgeon or anesthesiologist will permit an oral blood pressure medication, heart medication, or anticonvulsant to be taken with a small sip of water the morning of surgery. If the patient's bladder is not emptied, the relaxation that is induced by medications and anesthesia will cause the urge to urinate for the patient. If an NG tube is expected during surgery, the patient should be explained about the tube and the potential of coming out of surgery with a tube down their throat. If the pre-op patient awakens and is restless, the nurse should sit and listen and try to dispel any fears. The nurse can offer a soothing back massage or provide sedation or medication as prior ordered. The PCA pump is only controlled by the patient. No other individual has the right to push that button to provide medication from the pump. Routinely, the surgical site will be shaved so there are no hairs on the skin, because hair is a #1 infection-inducing agent in the operating room. The skin will also be cleansed, sometimes with chlorhexidine, the morning before surgery, or the doctor will tell the patient the skin will be cleansed in the operating room. Venous return is often hampered during surgical procedure because of the position on the operating room table and the pooling of blood in the lower extremities. Stasis, or the slowing of the flow of blood, places the patient at risk for a thrombophlebitis. Coughing with most eye, ear, nose, or throat surgeries, as well as any spinal or intracranial surgeries, is contraindicated. Deep breathing is always encouraged, but the nurse needs to ensure that coughing is appropriate for the type of the surgical procedure that was performed. The family is provided instructions as to when to come to the hospital prior to surgery and how long the surgery will approximately last. The surgical procedure site that is indicated on the consent should be verified and the same as what the patient states. The procedural site will be verified and marked with indelible ink in the preoperative holding area by the surgeon. The nurse should complete all the items on the preoperative checklist that can be accomplished ahead of time, so that way the nurse is not hurrying, which would increase mistakes and possibly prevent the delaying administration of any pre-op medications. The ability of the body to process medications and chemicals is influenced by age, sex, and race or ethnicity. Because of the decreasing liver and kidney function that occurs with age, older adult patients, especially older than age 75 years, will often need reduced dosages of preoperative narcotics and sedatives. The nurse should observe for signs of toxicity. There are cultural differences in drug metabolism. Asians, specifically Chinese individuals, metabolize psychotropic drugs differently from other ethnic groups. Valium can cause greater sedation with routine doses. Atropine is metabolized differently and can affect an accelerated heart rate. And Asian patients need to be monitored closely whenever receiving any of these medications. The nurse should always remind the patient to use the call light before attempting to arise from the bed. Once the patient has left the room and headed for the operating room, the nurse should prepare the patient's room for their return, gathering any supplies that might be needed. The surgeon is always the head of the surgical team, and anesthesia works in cohesiveness with the surgeon to provide the appropriate anesthetic for the procedure. The temperature in the operating room is kept between 66 to 70 degrees Fahrenheit. This will discourage any microbial growth, and it also assists the surgical team, keeping them comfortable underneath the bright lights, as well as in the layers of the surgical clothing that they must wear. A scrub person is either a surgical technician or it can be a specialty trained nurse that can be a practical nurse or a registered nurse. The time out, the team pauses to ensure that every member agrees with the procedure to be performed. The circulating nurse reads the consent on the chart, provides information such as prosthesis that will be used, allergies to be aware of, any specifics that the whole team must agree on before the surgeon drops the knife and begins the surgical procedure. Patients are classified for anesthesia according to their age, physical condition, and risk status, and they are assigned a risk potential. The choice of anesthetics depends on the type of surgical procedure that is going to be performed, as well as any risk potential. General anesthesia is induced by the administration of an inhalation agent or by medication that is introduced through the IV. During general anesthesia, the patient is kept in a deep sleep state with muscle relaxers, and they're not aware of their surroundings. An endotracheal tube or a nasoendotracheal catheter may be placed to maintain the airway. Placement of a laryngeal mask is another option. An accurate height and weight must be stated on the chart before anesthetic medications will be provided. A regional anesthetic is considered more economical than a general anesthetic, and a regional anesthetic also promotes less complications for the patient. For moderate sedation, the patient is monitored closely for blood pressure changes, oxygen saturation, carbon dioxide levels, and heart activity. Carbon dioxide levels are monitored by capnography, which is the measurement of the inhaled and the exhaled carbon dioxide. A local anesthetic is one that is applied to a very specific area. A good example would be an individual having a tooth drilled and filled at the dentist's office. Counts of sponges, sharps, and instruments are performed to verify that no equipment has been left in the wound. The cool atmosphere, cool IV fluids, inhalation of gases, and exposure of body surfaces will lower the patient's normal body temperature. Sometimes hypothermia is desirable for a lengthy procedure to help decrease the metabolic needs of the body. Hypothermia can adversely affect cardiac functioning and may make the body more susceptible to infection, and it can increase bleeding time and delay wound healing. Maintaining normotemperature has been found to decrease the postoperative wound infection rates. Prophylactic antibiotics are to be given 1 hour prior to the surgical incision, as it has been found that's when they work the best. Malignant hyperthermia, this is an inherited disorder. In patients that have this disorder, muscle metabolism and heat production increase rapidly and uncontrollably, in response to the physical stress of surgery and some anesthesia agents. Fever, tachycardia, cyanosis, tachypnea, muscle rigidity, diaphoresis, hypotension, and irregular heartbeat will develop. If not treated appropriately and quickly, the patient will go into cardiac arrest.